Hello and welcome to Eye Insider Ophthalmology Simplified. In today's class, we'll discuss regarding amblyopia. So it is the reduction in misdirected visual acuity due to defective central visual processing. So coming to the types of amblyopia, we have strabismic, refractive amblyopia, visual deprivation amblyopia, organic and idiopathic amblyopia. So in strabismic amblyopia, it is due to squint in one eye and the other eye takes the fixation. The squinting eye goes into the amblyopia, so it is commonly unilateral. Refractive is due to anisometropic, in which there is dissimilar refractive errors in the two eyes. Isometropic means there is high uncorrected refractive errors in both the eyes. Meridional is uncorrected bilateral astigmatism in eyes. Visual deprivation is the most severe form, in which it can occur in congenital cataracts, corneal opacities, etc. And organic amblyopia might have some subtle retinal damage or neurological damage. And in idiopathic amblyopia, the reason for amblyopia is unknown. So these are the types of amblyopia: strabismic amblyopia, refractive amblyopia, visual deprivation, organic and idiopathic amblyopia. Now coming to what are the clinical features of amblyopia. So to describe it in the form of Snellens visual acuity, we have visual acuity in the eye there should be a difference or greater than or equal to 2 lines on the Snellens chart if the amblyopia is unilateral. And if there is bilateral amblyopia, there should be the visual acuity of 6/12 or worse in both the eyes without any organic cause. They also show phenomenon called as crowding phenomenon. So in it is also called as separation difficulty. So what happens is that the patient will be able to see the individual letters with clarity, but if the same line has multiple letters, the patient will not be able to identify them. And when we place neutral density filters in front of these eyes, what happens? There is no reduction in the visual acuity in amblyopia. So what does this neutral density filters do? They reduce the amount of light which is reaching into the retina. So therefore, neutral density filters in retinal lesions, glaucoma, and in case of some pathology, the vision is reduced. So this is also known as ammann phenomenon. So there is no reduction in vision when the neutral density filters are kept in front of amblyopic eyes. The fixation might be eccentric, so they do not have fixation over the macula, and the contrast sensitivity is also reduced. Coming to the treatment, that is management of amblyopia. So the management includes treat the cause, correction of the refractive errors, and use of amblyopic eye. So we force the use of amblyopic eye and reduce the use of better eye. So what should we do in these 3 cases? First one, we should treat the cause. So what are the causes? So if there is any corneal or lenticular opacity, so we have to get it operated for that at the earliest. And if there are any refractive errors, we have to correct it. If the patient is having astigmatism, myopia and anisometropia, there should be full correction should be given. In case of hypermetropia, there should be either full correction or the under correction according to the age we have to find out. So full correction is required if the patient has esotropia along with refractive errors, and under correction is required if there is no esotropia, only refractive error. So how do we prevent the use of better eye? We can give occlusion therapy, penalisation, so it is pharmacological, and we also have Bangerter glasses, filters. We'll discuss in detail regarding each of these now. So this is very important for our exam point of view. So we have this occlusion therapy or patching. In this, occlusion of sound eye is performed with the help of either a adhesive patch or spectacle mounted occluder. So this obligates the use of amblyopic eye. So how long should we give this? So 2 hours daily is required in case of moderate amblyopia, that is 6/12 to 624 vision, and 6 hours daily is required in case of severe amblyopia, in which it is counting fingers 3 to 6 meters. So till what age or at what age can we start or continue this therapy? So studies say that 3 to 7 years patients have maximum response, 7 to 12 years have 50% response, and 13 to 17 years have 25% response. But this response is more in compared to the ones if it is not done at all. Understood? So it is better to do if it was not done anytime, whatever the age be. Understood? So this is the age. So till how long should we give this occlusion therapy? So initially we give it for a 12 weeks period, then again we have to recheck, and if there is any residual amblyopia present, we have to repeat. Coming to penalisation. So it is a pharmacological method to which uses cycloplegics. So this dilates the eye and relaxes the sphincter muscles, which forces the use of other eye. So we can use atropine sulfate 1% in the sound eye, so it is almost equivalent to 6 hours patching, but there are side effects with atropine. Therefore homatropine 5% can also be used, and it has been said it is equivalent to almost 2 hours of patching. Coming to Bangerter filters, these are translucent filters which are placed in front of sound eyes. For full-time wear these are, and the use of these filters is almost equivalent to 2 hours patching. So what do these Bangerter filters have? So they have different density filters which give different degree of defocus, leading to use of other eye. Coming to recent advances in the management of amblyopia, we have binocular therapy. It includes perceptual learning. So what does this mean? Perceptual learning means long-lasting changes in the perception, the ability to perceive, so which is activated from practice or experience. So they give visual tasks to the patients which are performed repeatedly. So this increases the visual acuity slowly. We have vernier acuity tasks. We have Gabor patches. We also have contrast discrimination, and there are letter identification in noise. These are some of the visual tasks which are given. Another binocular therapy is Dichoptic training. In this, it gives independent and visually different stimulus to which is presented to the each eye. Whereas in perceptual learning, single visual stimulus was given to both eyes simultaneously, right? Here we are giving independent and visually different stimulus presented to each eye. So in front of amblyopic eye, we give higher contrast, and in front of the other eye, we give a lower contrast image. So this improves the fusion and slowly reduce the contrast which is presented to the amblyopic eye, so that both the contrast are equal and there is binocularity established. So it can be done with the help of iPad therapy or also with the help of iBit system. Then we also have pharmacological therapy in the recent advances, which includes levodopa carbidopa combination. So what does this help in? So it reduces the levels of dopamine in the retina. So it increases. In amblyopia, the levels of dopamine are reduced and it increases the level of dopamine. So it is given in the dose of 4:1, 0.5 to 2 mg per kg per dose is given. And carbidopa does not cross the blood-brain barrier. So the combination reduces side effects. Then we have citicholine. So citicholine is a phospholipid enhancer, so it helps in the biosynthesis of phospholipids. So this increases the neurotransmitters in the brain. It can be given IM 1 gram per day for 15 days or oral 250 mg OD if the age is less than 5 years, and in more than 5 years 500 mg OD for. Thank you for watching. Please subscribe to my channel. Bye bye.